Hi, welcome everyone. Welcome. We're just going to wait a few minutes so people can join. I am Julie Montgomery. I'm the VP of SID Washington. I manage partnerships along with programs. We are so excited to have you here today. Welcome everyone. Just to make sure you all are at the right place, today we are having a panel on the update of COVID-19 and the science and trends from an international development perspective, hosted by SID Washington and sponsored by FHI 360. We're just going to wait one more minute and then we're going to get started. If you'd like to introduce yourself, who else is here, please put it in the chat box. We'd love to know where you're calling from, which organizations you're with. Please put in the chat box. All right, I started now. So as I said, welcome everyone. I am Julie Montgomery. I'm VP at SID Washington, managing membership, partnerships, and programs. Today's event, we're so excited. We really do have a great a panel of speakers today who are going to share their expertise on the recent science and trends on COVID-19, particularly from the international development lens. As I said, this is sponsored by FHI 360. Thank you, FHI 360. We're very happy to have you as series sponsor and also event organizer. And this event is a part of a SID Washington series on the continuing impact of COVID-19. I just wanted to note a few things before we get started. One, you probably all have already, when you signed in, you noted that we are recording this session and we will be sharing it publicly through our network and social media channels. We also have live translation, closed captioning, which you can access through your own individual settings. If you have any questions for the speakers today, please post them in the Q&A box. Note that it's a Q&A box, not the other chat box. And if it's for a specific speaker, please note that also in your question. We have some time set aside after the session, after the discussion and the presentations for Q&A, but we may not be able to get to all of them, but we're going to try to do our best. And if you're not already involved, like in terms of, thank you for being here, but we wanted to offer you some ways to get more involved in SID Washington's besides, attending our events, and we hope to see you at future events. If you're not on our newsletter, please sign up for our newsletter to get the latest information about our members, about upcoming events, and other resources, jobs, our members events, and also follow us on social media. Now, I think you all know about SID Washington since you're here, but if you don't, SID Washington is a part of a global network, the Society for International Development, and it's a network that was founded in 1957. Our purpose is and mission is to bring together our members and individuals to discuss, share, learn, connect with each other. We're a very diverse network with representing organizations from all aspects of international development, from universities, from NGOs, from the private sector, from small businesses to multilaterals. We really represent the entire kind of spectrum of international development. And we bring together people from all parts of their career. So whether you're just starting out or whether you are a retiree, we really, welcome individuals and organizations as a part of the network. And one last thing, because I won't come back at the end, I'm going to turn it over to the panel shortly. Please don't forget to fill out the survey after the event. It really is important to us. But before we get started, we have two polling questions for you now. So the first is, are you a SID-W member? Are you a SID-W member? We really would love to kind of see who's joining us. We have members from all around the country, and it's been great because as we are virtual, We have had, even more participation from all around the country and the world. So let's see, Malvika, can you show the results of that panel? All right. Okay, so are you a SID member? No. Okay, so 60% are no. All right, if you are not a SID member and you want to learn more about the benefits of being a member, please reach out to me or to Malvika. I'll put my email in the chat shortly. All right, how about the next one? Where are you all joining from? Can you put the next poll up? All right, I don't see the poll. Okay, all right, looks like there's some issues with the poll, the second poll. So why don't you just, if you haven't yet put it in the chat box, please go ahead and list where you're joining from us today. All right, so now I will turn it over to the panel and this really all-star panel, but I want to first introduce our moderator, Dr. Timothy Mastro, who is the Chief Science Officer at FHI 360. He's also an adjunct professor at the School of Global Public Health at University of North Carolina at Chapel Hill. Tim oversees FHI 360's research and science-based programming in the United States and all around the world, over 50 countries around the world. Prior to his time at FHI 360, he was at CDC. He also worked in Thailand for a while with at the time Ministry of Public Health and US CDC collaboration. But he started his career actually the physician and medical coordinator of the UN Border Relief Operations, providing health services for populations of displaced Cambodians. So he's had a really a very impressive career. So we're so excited to have him here today. He is going to introduce the other speakers. Tim, over to you.
Well, Julie, thank you very much for that generous introduction. And if we could go to the first slide, please, and then I'll introduce my three FHI 360 colleagues that are here with us today. Great. Well, thank you very much. It's really a privilege for us to be joining the SID Washington organization today and your constituents. The tagline of FHI 360 is the science of improving lives. So all four of us today are scientists. First, I'll start off to introduce Dr. Otto Chabakuli, is a physician who completed his medical and public health training in South Africa. Dr. Chabakuli currently serves as FHI 360's regional director for East and Southern Africa, where he oversees a portfolio of 18 country offices. He has extensive experience in clinical services, teaching, research, and management in the public, private, and not-for-profit sectors in Africa. And he's also adjunct professor of the MPH program at Howard University, where he teaches global health. Dr. Nirupama Sista has a PhD in microbiology with education and training in the United States and India. Dr. Sista's research career spans more than 25 years with experience in the pharmaceutical industry, clinical research organizations, and a large global health and development organization. Dr. Sista currently serves as Director of Research and Development at FHI 360, and she's also Director of the NIH-funded HIV Prevention Trials Network and the NIH-supported Director of the COVID Prevention Trials Network, which she'll tell you about. And finally, Dr. Christian Pitter is a pediatrician and public health physician who currently serves as director of our global health, population, and nutrition at FHI 360, responsible for our extensive global health portfolio. He has a long career in global health, including with the US CDC and postings in Uganda and Cambodia, with a focus on PEPFAR, HIV prevention care and treatment programs. He currently oversees FHI 360's broad global COVID-19 programmatic portfolio, which he'll tell us about today. So next slide, please. This is the outline. I'll review global and US epidemiology. Otto will give us the view from Africa. Niru will summarize COVID vaccines, and then Christian will talk about the FHI 360 and our global response. Next slide, please. Next slide. So we've all been living through COVID for more than 2 years. It's been quite a remarkable journey. And shown here is the epidemic chart, epidemic curve for the epidemic starting back in early 2020 when SARS-CoV-2 emerged from Wuhan, China. And there's still some controversy over how the virus made it from its natural reservoir into humans and the role of a wet market in Wuhan. At first, we thought this was going to be a somewhat stable virus, but then in the summer of 2020, we had the first mutation, if you will, the D614 variant emerged that then dominated. And that was a forerunner really of what we saw over the next 2 years was a rapidly changing virus with variants of concern emerging, the alpha, beta, gamma, and then the delta surge, which shown there in the early part of 2021, which caused a very huge surge in India. And then it sort of was stable, if you will. But then in November of 2021, the Omicron variant with both the BA1 and the BA2 subvariants emerged and caused this huge spike in the world. So we've had a total of 470 million reported infections, resulting in 6 million reported deaths. But we know that these are large underestimates due to under-ascertainment of cases and deaths and underreporting of these. So these are minimum numbers. Next slide, please. So there's many ways to look at the epidemic. This is, I'm sure you all look at these charts in the New York Times and the Washington Post. They do a good job portraying the information. These are hotspots based on where cases were reported in the last week. The darker colors are the hot spots, the yellower colors are the cooler spots. And it's been really quite transformative week by week, month by month, as the epidemic heats up in various parts of the world and cools down. Currently, we're seeing very hot spots in places that previously had controlled the epidemic well, like New Zealand, Australia, Vietnam, and South Korea. Many European countries are very hot right now. And some of the cool countries are cool because there's little COVID. And as Otto will tell us, in Africa, there's a substantial amount of underreporting of cases in Africa. China, as you know, tried to totally control the epidemic, and they've been yellow throughout the whole time. Next slide, please. So there's been this great variability in global epidemiology and response. I've chosen just two little vignettes here. One is the news this last week from Hong Kong. That huge spike that you see there on that curve is a spike in cases in Hong Kong, really shutting down the city because they had tried to keep COVID out completely. So there was very little immunity that resulted from previous infection. They're using the Chinese vaccines, which are much less effective than the mRNA vaccines we're using in America, and Neil will review that for you. And then in the UK, probably as just a function of just being worn out with COVID and sort of just can't take it anymore, the UK lifted all remaining COVID restrictions about a month ago. And you'll see at the bottom now, there's a resurgence in Omicron-related cases here. So we continue to see this ebb and flow of the epidemic, and a really difficult story to explain much of the time. Next slide. So now I'm going to switch to the United States. This is the curve for the United States alone. And you'll see a few things of note here. So these are the daily reported cases. And we had a large surge at the winter season after the end of the first year, December, January of 2020, 2021. That's before we had vaccines. And then in early 21, we started rolling out our vaccines, which are highly effective. And by June of 2021, we thought we might have been out of the woods. Vaccine scale up was advancing. Transmission was down, and then the Delta variant emerged, and that resulted in a large close down of activities in the United States. And then in November, the Omicron surge. So the panel on the upper left just shows that we're still experiencing a very severe epidemic in the United States. We have more than 1,000 deaths per day. And at this rate, we will hit the unfortunate milestone of 1 million Americans who have died from COVID within about a month from now. So still a very high rate of death and a great number of cumulative deaths. Shown on the upper right is the vaccination status in the US. We started off quite good in 2021, then we plateaued. And if you look at the ages 5 and up, so those are people for whom vaccines are authorized for use. And we have a very difficult 30% who've not been vaccinated. And a large amount of the death in serious illness from COVID is among the people who remain unvaccinated. And this has been a real challenge for both the United States and other countries to contend with. Next slide. This is perhaps one of the most important slides to take away. Now, what we learned when Omicron emerged in November was that people that were fully vaccinated could really become infected with Omicron. However, those unvaccinated were, if you look at the panel at the left, were 3 times more likely than the vaccinated to get infected and therefore be able to transmit. But the real difference is shown in the right panel, where the death rate from COVID is very low in those that are fully vaccinated, and it's fully 10 times higher for the unvaccinated. So the intensive care units in American hospitals that have COVID patients are filled with the unvaccinated who get severely ill because of lack of immunity from protection from vaccines, and they're contributing the lion's share, more than 95% of the deaths. Next slide, please. So we're all trying to contend with COVID as we move into the 3rd year. 1 month ago, CDC rolled out this new community level and indicator format of how to characterize the epidemic in the United States. Previously, they'd only used COVID cases, but it's important to capture not just COVID cases, but the severe illness that results from those that burdens our healthcare system. So this new schema with low, medium, and high risk is based on 3 parameters: the number of cases in a population within the last week, the number of COVID-19 admissions to hospitals, and the percent of inpatient beds that are occupied by COVID patients. So that results in every county in the US being rated as low, medium, or high. Next slide. So we have more than 3,000 counties in the US, and the CDC data characterize each county by low, medium, or high. And CDC has a very convenient tool you can use. You can go to the website, enter your state, enter your county. It'll tell you if you're low, medium, or high. They recommend that for fully vaccinated people in low areas, you do not need to wear masks in indoor settings. So here at FHI 360, both in our Durham office, where I'm sitting, or in Washington, DC, masks are no longer required. We do require full vaccination for our staff to come in, however. Next slide, please. So, how are we going to deal with the COVID epidemic going forward? Can we deal with this as an endemic virus that simply circulates through the population? One thing to compare, and these data are from CDC from 2 years ago, and looking at influenza, good old flu, which we've dealt with essentially forever, and it's an endemic infection that has a seasonality between October and March is the flu season. And what we would see in a typical year in the United States is about 50 million cases of flu, resulting in at least 25 million medical visits, more than 500,000 hospitalizations, and perhaps 50,000 deaths from influenza every year. And this is something that we simply took in stride and didn't even note. However, please note that for COVID, we're still having 1,000 deaths per day. And if it keeps up that rate, we would have more than a few 100,000 cases in the course of a year. So you think about that as we go forward. And now I'm going to turn the stage over to Otto Chabakuli to give us the view from Africa. Otto? Next slide, please.
Thank you, Tim, and greetings, everyone. Next slide. So it's been about a year when the General Secretary of WHO was addressing the WHO's executive board and warned of a catastrophic moral failure should vaccine nationalism win the day. And now about just over a year since COVID-19 vaccination rollout started, and we can see clearly that one continent, Africa, is left behind. So as of March 20th of this year, only 10% of the African population has been fully vaccinated. Think about that compared to the coverage in the United States, North America, and Europe, that is between 65% and 80%. So truly we can say that catastrophic moral failure has come to pass. But in response to these inequalities, unacceptable inequalities, the WHO has not relented and led a strong advocacy. And it managed last year to secure voluntary sharing of technology through non-exclusive agreements. In other words, about 6 African countries today have now received the technology to be able to produce mRNA vaccines. And in the medium to long run, it will palliate to the gap of manufacturing capacity on the continent. Now, in the meantime, Africa continues to receive donated vaccines, and more doses are coming in from manufacturers through the COVAX mechanism, a mechanism that has now delivered about 1 billion doses. Now, with this stock in hand, the revised vaccination coverage target is now to reach 45% of the population by mid-year. So we're talking about jumping from 10% to 35% in about 3 to 4 months. Now, as vaccine supply ramps up and we have all these doses now, the challenges for poor countries is to face these hurdles, such as gaps in the cold chain. And we know that cold chain is necessary to safely move vaccine doses from the receiving ports to where the services will be delivered and inoculation done into arms of people. And also countries are also contending with vaccine hesitancy. Next slide. So while it is true that relative to the impact of COVID-19 that we see elsewhere, like Tim has just described right now, Africa seems to have come out of it much better than feared. There is a general agreement that the data reported on COVID-19 cases are an underestimation of the true extent of the pandemic. So these graphs I just wanted to show you very briefly in comparison to the number of cases in the US, will be the red line, and Europe in blue line. See how Africa at the bottom in green line is faring. But that should not be, we should not be deceived by this picture, because as we know, number of COVID-19 cases reported is influenced by several factors, including the country's ability to test, capacity of testing, the proportion of asymptomatic illnesses among infected individuals. And we know that Africa has a very large population of young people who tend to be asymptomatic, and the community's health-seeking behaviors as well as access to services generally. Now, if you take all these factors and reasons together, it is safe to say that the true number of infections has not been fully determined. And we will only be able to characterize properly and accurately what is happening in Africa if we conduct seroprevalence surveys, which will be needed to establish the true exposure to SARS-CoV-2 virus across populations. Next slide. Now, for that reason, I wanted us to share the findings from 3 studies just as an illustration of the extent of transmission in communities. The first study was conducted in Kenya in 2020, and it analyzed 3,098 blood samples from the Kenya National Blood Transfusion Services. Now, the findings there suggested, this is already at the beginning of the pandemic, it suggested that the national seroprevalence in Kenya was 4.3% at a time when Kenya had only reported 20,636 cases. The second study is from Malawi. It studied 5,085 samples, also from blood transfusion donors. Here too, we can see that the findings suggested higher transmission than reported number of cases. So the national seroprevalence in Malawi was estimated at 18% in October 2020, and that prevalence rose to 65% in May 2021. The third and final study I wanted to share with you is a seroepidemiologic survey in Gauteng, South Africa, where the author studied 7,010 participants in 2021. Remember that Gauteng was the epicenter of the Omicron in Africa at the time. It also suggested a much higher seroprevalence in communities, and it was highest in adults over 50 years of age at about 79.7%. So in light of all this evidence, a number of scientists and many people are now hopeful that the immunity acquired through natural infection is going to go a long way in protecting populations against severe disease and death in future waves. Next slide. Now, The increase in vaccination coverage has done a great job of keeping us away from hospitalization. And many people are now asking if the pandemic is truly behind us. I wanted to share this graphic by Victor Sting. It illustrates the various ways COVID-19 epidemic impacts on us. We shouldn't just focus on the number of cases, hospitalization, and deaths. With the decline in numbers of hospitalization and deaths, we are headed toward the tail of the first wave, which is shown in purple. And that is what many of the news that you've heard the past 2 years have been focused on. But the second green curve represents an increase in adverse outcomes from urgent non-COVID conditions such as HIV and TB. These are the conditions and programs that suffered from diversion of resources during the emergency COVID-19 response. And then we've got a third wave in blue, which is related to interrupted care on chronic conditions such as cancers and non-communicable diseases. And finally, the fourth wave in red will be sustained over a longer period of time. And that one includes psychological trauma, mental illness, burnout, and economic fallouts. Next slide. Now, there are indications that the secondary shocks of the pandemic are already taking hold. The recent Global Fund's result report, which was published last year, alerted to the devastating impact of COVID-19 on HIV, TB, and malaria programs. And similarly, credible reports from the World Bank and Brookings Institution predicted dire effects of COVID-19 on food and income security on the continent. And both of these are significant factors associated with increasing adverse outcomes from HIV and TB and malaria. Now, when you look at these three conditions and put COVID-19 deaths in perspective, you will see the blue bar that represents the number of COVID-19 deaths in 2020. It represents really a small proportion of deaths compared to HIV, which is the yellow bar. TB will be the green bar, and malaria, the orange bar. Again, with a footnote that COVID-19 data is an underestimation. So this picture is likely to get worse in 2021. Next slide. So far, the emergency response to COVID-19 pandemic has leveraged the diagnostic laboratory, hospital, and clinical infrastructure, which was built over several decades through investment from PEPFAR, the Global Fund, and other donors. In her World AIDS Day message, the UNAIDS Executive Director eloquently summarized the position of many policymakers, and I want to quote what she said. She said, "There is not a choice to be made between ending HIV/AIDS pandemic that is raging today and preparing for the pandemics of tomorrow. The only successful approach will achieve both, and as of now, we are not on track to achieve either." So I would like to conclude by saying that from the available evidence and understanding of the African context, it is wise to design future investments in COVID-19 with the aim to, number one, strengthen health systems, and number two, integrate with other epidemics such as HIV, TB, and malaria. Thank you for your attention. I now turn over the floor to my colleague, Nirusista.
Thank you, Otto, and good day to all. Next slide. I'd like to start first by describing what the COVID-19 Prevention Trials Network is before going into the efficacy of various vaccines and the duration of how long these vaccines last, as well as whether we can mix and match vaccines. So back in February or March of 2020, when the COVID-19 pandemic was first unraveling, the NIH used its existing research framework and existing research networks in infectious diseases, including particularly the HIV Prevention Trials Network, to form what is called the COVID-19 Prevention Trials Network. FHI 360 has been and continues to be the leadership and operations center for the HPTN for now over 2 decades. And as such, we also assume the responsibility of being the operations center, one of the operations centers for CoVPN, the other being at the Fred Hutchinson Cancer Center. And we have a soup to nuts approach. We are involved in clinical research from the concept and protocol development all the way through community engagement and communications. And the COVID-19 Prevention Network has sites globally, and the right-hand side of this slide shows you the global presence of the clinical research sites included in our network. Next slide. So before we get started talking about the efficacy of various vaccines, it's important to remember that it's impossible to compare vaccines head-to-head due to the different approaches that have been taken in designing these respective studies. That said, all the vaccines that have been achieved by the have achieved WHO emergency use listing are highly effective in preventing severe disease and hospitalizations. Next slide. So this slide actually is shows a lot of data, so I'll walk you through it. These are the vaccines currently authorized by the WHO. The Sputnik vaccine has been put on hold due to the Russia-Ukraine war. The left-hand side of this slide shows you the different manufacturers. Note that the Oxford AstraZeneca vaccine and the Novavax vaccine is also manufactured by the Serum Institute of India and is available in many parts of the world. The vaccines have different platforms as shown on this slide and in the middle. Many countries have approved these vaccines. The cold chain is very important because it does impact supply chain logistics. But most importantly, I want to focus on the efficacy. And the right-hand side two columns show the efficacy against severe and symptomatic infection. And then the very right just shows the acquisition of infection. So if you look at the efficacy of against severe and symptomatic infection, a range of vaccine efficacy is shown here. The higher end of it is for the early viruses, including the Delta variant. So many of the variants are sort of geared towards the very high range of the vaccine efficacy. Again, we're talking about severe and symptomatic infection. And the lower end of that range is against the Omicron variant. And particularly if you note the last two rows, the Chinese-made vaccines show about 37 to 50% efficacy against the Omicron variant. Next slide. And that's important because as shown on this slide, nearly half of all doses that have been provided thus far come from those two vaccines. And the biggest takers of these Chinese vaccines are shown on the right-hand side of the slide, and the different countries that are currently delivering those vaccines. Next slide. So this vaccine efficacy that I spoke about is the efficacy of the primary series. Most of the primary series vaccines are 2 doses, except for Johnson & Johnson, which is a 1-dose primary series. But we all now are, many of the places in the world are also using boosters. And so this slide shows you vaccine effectiveness of the boosters. And the takeaway message really first is that boosters work again in preventing hospitalization. So this slide is data from the United States and depicts the vaccine effectiveness of 2 versus 3 doses of the mRNA vaccines, either Pfizer or Moderna, for both Delta, which is shown in blue, and Omicron, which is shown in red. And about 2 weeks after the second dose, and up to about 6 months, you can see that the vaccine effectiveness against hospitalization remains very high for Delta. After 6 months, goes down a little bit, but reassuringly is boosted after a 3rd dose. The curve of the Omicron is not as distinct. There is reduced efficacy right at the very beginning of the second dose, but it is diminished at almost 50% by 6 months after the second dose of the primary series. Again, what's reassuring here is after the 3rd dose, after a booster, that immunity is restored to almost 90% for hospitalization, and as we've seen from Tim, even more so for death. Next slide, please. So does this immunity last? And so this slide is again an example, and I failed to mention even the previous slide, the same sort of graph pattern is shown against all the vaccines. Similarly for this, does the immunity last? I'm going to use the AstraZeneca vaccine as an example, the Vaxzevria, but note that we see the same pattern with pretty much all the vaccines. So at the very left-hand side of those graphs, in squares, we see the vaccine effectiveness against Delta variant in the open circle against Omicron, right after the 2 doses of the primary series. And as you can see over time, this immunity wanes, particularly with the Omicron around 20 weeks or so, you see no immunity at all, no vaccine efficacy against the Omicron. Again, what's reassuring is that when boosted with, in this case, 2 mRNA vaccines, either the Pfizer or the Moderna, vaccine effectiveness is restored to very high levels with the Delta variant, and also about 40 to 70% with the Omicron variant, although that too then begins to wane over time. Next slide. So we just saw some data about mixing 2 different types of vaccines. The AstraZeneca vaccine is the primary series, and then the mRNA vaccines. NIH conducted another study using Johnson & Johnson or the Moderna or the Pfizer as the primary series, and then combining them for a booster with each of these vaccines, leading to about 9 combinations. And again, the takeaway there was that all booster vaccines were immunogenic, and the fold increase from baseline in both binding and neutralizing antibody titers. This is a proxy marker for vaccine efficacy. And the fold increase from baseline was similar, if not greater, for heterologous boosts. All vaccines had no safety concerns as well. Next slide. So currently, the CoVPN is conducting a study in many parts of Africa, as shown on the lower right side of the slide, where we are evaluating the Moderna vaccine in people who are living with HIV/AIDS, who are either SARS-CoV-2 uninfected or have been infected at baseline. And this study is ongoing and with the goal of enrolling over 15,000 participants. But what's very timely is that Moderna has reached a preliminary agreement to build a COVID vaccine manufacturing plant in Africa, with the hope that accessibility to these vaccines will be further increased. Next slide. To summarize then, the primary series vaccines do offer initial protection. Vaccine effectiveness is very good for hospitalization and death for up to 5 to 6 months. Boosters restore this vaccine efficacy against disease and hospitalization. Neutralization activity, which is a proxy marker for vaccine efficacy, is not, I didn't show you the data, but is similar for Omicron BA.2 variant, which is now quite in the news, as with BA.1. So the takeaway there is that there is protection with the booster against this variant as well. And in addition, although I didn't show you the data for this, in addition to reducing the risk of acute illness, COVID-19 vaccination may also have a protective effect against long COVID. Thank you, and I'll turn it over now to Christian.
Thanks, Niru, and greetings to all. So as an international development organization, the COVID-19 pandemic has had a number of impacts on our work. First and foremost, we were faced with the challenge of keeping our staff and program beneficiaries safe, which required the rollout of PPE and other non-pharmaceutical interventions in the offices, clinics, hospitals, and schools where we work, and new approaches for communicating and providing oversight to ensure high-quality services. Because of the professionalism and flexibility of our staff working in more than 70 countries around the world, we were able to continue to perform research and deliver services in HIV, TB, neglected tropical diseases, reproductive health, and so many other areas for the communities that we serve. Crucially, we also turned our attention to how we could help confront the pandemic itself. And like the rest of the world, we leveraged what we had, we embarked on a steep learning curve, and we took on the challenge of supporting the global response to COVID-19. Next slide, please. Altogether, FHI 360 implements COVID-19 response activities in 64 low and middle income countries around the world. Next slide, please. Our diversified COVID-19 portfolio includes strengthening clinical case management, building medical oxygen ecosystems, risk communication and community engagement, support for diagnostics and surveillance and contact tracing, vaccination service delivery and demand creation, procurement of equipment and consumables, supporting national level planning and advocacy, building health worker resilience, and crucially, supporting mental health. And then the cross-cutting areas of telehealth, knowledge management, research, and coordination. I'll take us quickly through some highlights of this work in the following slides. Next slide, please. So we're working to strengthen the medical oxygen ecosystems in 20 countries, providing technical assistance, equipment, and supply and storage of medical oxygen, as well as engaging in policy, financing, and regulatory activities. For example, in Nepal, we conducted a rapid assessment of needs and gaps, and then provided training for 280 doctors and nurses, and procured oxygen cylinders and concentrators, along with other equipment. Next slide, please. In Indonesia, we supported the recruitment of over 1,000 private sector vaccinators in 780 vaccination sites, resulting in over 180,000 people receiving vaccinations. Next slide, please. In Bhutan, we developed and adapted clinical training materials on COVID-19 case management and trained 390 healthcare workers and 24 national clinical trainers. Next slide, please. As described earlier, there's a stark divide in access to COVID-19 vaccines around the world, with much of Africa not yet receiving a fair share of vaccines. So in addition to expanding vaccination service delivery and demand creation, we've also supported advocacy efforts. For example, we supported the Ports to Arms Global Summit last month in Abuja, convened by the WHO Special Envoy for the ACT Accelerator and the chair of the African Vaccine Delivery Alliance, which brought together leaders from civil society, industry, and governments to address the bottlenecks and move towards greater access to COVID-19 vaccines, treatments, and tests. Next slide, please. Over the course of the past 2 years, FHI 360 has developed over 100 tools and technical resources, including, crucially, a clinical care pathways guide. This guide enables health systems to situate COVID-19 response activities within the primary healthcare system, avoiding duplication and verticality, and moving towards an integrated approach that builds upon and leverages the primary healthcare system. Next slide, please. Now, the importance of social and behavior change approaches in deploying health interventions has been underscored by the COVID-19 pandemic. This includes research, strategy development, coordination, human-centered design approaches, and social marketing, and a variety of other interventions. Next slide, please. Last year, FHI 360 published a COVID-19 SBC toolkit to support governments and international local organizations to design and implement evidence-based COVID-19 SBC programs. This toolkit provides guidance for strategy development, as well as other tools to conduct situation analyses, rapid audience assessments, audience profiles, and messaging. Next slide, please. And in Jordan, we supported 2 national SBC campaigns, conducting rapid research to guide multi-channel campaigns that use broadcast media, social media, and community outreach. The campaigns resulted in shifts in attitudes and norms and improved vaccine uptake. For example, 40% of those exposed to the Do Not Hesitate campaign self-reported that the campaign's convincing tone and clear information influenced them to get vaccinated. Next slide, please. In collaboration with the government of Côte d'Ivoire, we conducted rapid surveys and interviews to understand the drivers of and the barriers to vaccine uptake among underserved populations. We co-created and rapidly tested new solutions to reach and motivate these populations, and developed and disseminated tools to strengthen the vaccination program. So taken together, FHI 360 has been involved in a wide variety of activities to respond to the COVID-19 pandemic. And we realize that as a global community, we still have quite some distance to go to achieve our objective of equitable access to vaccines and clinical care around the world. But as I'm sure you will agree, there's no more pressing imperative than this. Thank you. Back to you, Tim.
Christian, thank you so much, and Niru and Otto for those terrific presentations. So if we could move to the next slide, I'll be very brief and concise, I hope, just in 2 slides to try and summarize the main takeaways from what's been probably the most profound 2 years in all of our lives. I think it's fair to say that at this point, high levels of community immunity due to vaccination and/or acquired infection could lead to COVID-19 becoming a manageable endemic infectious disease either this year or in the near future, but we're just not there yet. We need to focus on averting severe illness and death, and we've heard from Christian that the interventions that are being rolled out are dramatically increasing our ability to manage sick people. What we've seen is that, from Otto described, that the COVID-19 related disruptions have exacerbated health and economic disparities, and several other disease programs are off track. So it has been very disruptive, and we need to get those back on track. Global vaccine inequity is a major barrier to epidemic control. Niru showed the data on where various vaccines are used. And it's been sort of the rich have gotten richer during this time. The better vaccines are available in resource-rich countries, and the less effective vaccines are used in much of the lower middle-income countries. So in addressing that equity that both Niru and Otto talked about is really one of the highest priorities for the coming years. New variants of the virus that can evade existing immunity are a substantial concern. You know, a year ago, we didn't see Delta coming, and it really changed the way we managed the epidemic. And in November, we didn't see Omicron coming. So while there's a sense that control measures are being lifted now, much of the US is green by the CDC chart. It's quite unpredictable when the next variant will emerge, but most viral evolutionary biologists thinks it's probably just a matter of time before that next variant comes. But fortunately, we think that the vaccines we have, as Niru pointed out, really can prevent the worst outcomes of infection. So our vaccination programs are going to need to adapt and evolve. There's active research going on trying to come up with a universal coronavirus vaccine that could actually potentially cover not just this strain of SARS-CoV-2, but other coronaviruses and perhaps all of the variants. And I think what we're going to see is that the focus on this virus is going to catapult the world of virology for both developing treatments and developing vaccines. I started my career in New York City when the AIDS epidemic got started, and we never could have conceived the way virology would have evolved to be able to come up with fantastic treatments for HIV infection. So I think there will be big advances in the coming years. We potentially can learn lessons from influenza. People get influenza shots every year. If you got a vaccine in the US, it was actually a 4-valent vaccine. You got a little piece of 4 different flu strains that are circulating that year. We don't know how this will evolve for COVID, but it's likely COVID vaccination will be a regular part of public health in the coming years. Next and last slide. So as Christian's pointed out, we have a better understanding of COVID-19 disease, and better treatments are on the near horizon, but inequity continues to exist in this area as well. Christian pointed out many interventions that FHI is rolling out with support from the US government. You've heard and read about new pills, oral pills that can treat early COVID infection. You may recall in previous years, I know when I worked at CDC, when we went on international trips, you would of course be encouraged to get a flu vaccine, but you would actually have a pack of Tamiflu, which is an oral drug that you can take at the early signs of flu to prevent you from getting sick. And we could have such treatments for COVID that at the early signs of COVID, you take an oral pill that prevents you from getting sick. We're not quite, the medicines do exist, but they haven't been widely distributed, and there again is inequity between rich countries and poor countries. So clinical management of COVID-19 is improving. We simply do a better job at all aspects of that. And we continue to see there's great variability in the global impact of and response to COVID-19, and we're all learning lessons that need to be shared. Prevention efforts, good old masks and social distancing continue to be important. And I think what we've seen in control efforts is politicians become fatigued with COVID, and they go from a lockdown to 4th gear. And I think there's a way you can go into first gear and 2nd gear and 3rd gear as you start opening up communities and societies. And there are encouraging developments on the vaccine and treatment manufacturing capacity, as we heard from Otto or from Niru, that Moderna is building a vaccine manufacturing plant in Kenya. And that's been a very encouraging sign that it's important that vaccines and treatments are manufactured in Africa, Latin America, the Caribbean, and Asia, so those countries have access to and control of the products. So that's just one level of capacity building that's needed, that has to happen on so many levels, and that would be a whole 2 hours to talk about capacity building around the world. And then if you look at the broad systems, the global framework and systems for pandemic preparedness and response didn't work this time. You know, despite really years of getting ready for the next big pandemic, what we saw was a failure of the global systems to do anything approaching equity related to both treatments, personal protective equipment, and vaccines. And we simply need to have a better framework for actually continuing to work on this epidemic and prepare ourselves for the next epidemic. So we have about 10 minutes left. We've had several questions that have rolled in. I'm going to ask my colleague Dorgum, who's I think been monitoring the Q&A, to maybe queue up some of the questions for us. Dorgum? You're muted, Dorgum.
Hi, yes, thank you so much. Well, yes, I can see 4 questions that have come in and 1 question that I believe was answered, but we could go back to it if necessary. The first question that came in is from Brittany. What are the steps used to increase testing and vaccine uptake in Africa?
Otto, maybe you go first, then Christian.
Yeah, so there are several things that are currently being done to increase vaccine testing access in Africa. The first biggest hurdle is around costs, the cost barrier. Just to give you an example to illustrate, Africa, there's no big health insurance coverage, so many people pay out of pocket. And PCR test costs ranges between $35 in South Africa to $50 in ECOWAS region in West Africa. So asking people to pay that amount of money in the economies of Africa is already a big barrier. So there is, Africa Union and WHO, a lot of people are advocating for pool procurement to find a way of supplying tests that is much cheaper. Adoption of new technology, I think rapid antigen testing, when it will come down to Africa, will also increase the capacity for testing. And, mapping hotspots for hesitancy and so on is also helpful for targeting behavior change communication and intervention generally. So that is what I can say so far. There are programs that are being innovative as well, trying to kind of integrate TB testing and COVID-19 testing at the same time as a way of reaching out people with similar symptoms. Over to you.
So Christian, you talked about risk communication and community engagement. That acronym doesn't roll off my tongue that well, RCCE, and also SBC, social behavior change communication. Maybe you could elaborate on how we're using those tools.
Yeah, and actually, let me take it one step back, because the question was asking about uptake, and uptake is a combination of access and utilization. And so you need both of those in place to be able to get to the uptake. And so right now we know that the access for example, vaccines is not there. But we also know that there is a fair amount of hesitancy among lots of communities. And this is where the SBC, RCCE come into play, because hesitancy is to a great extent malleable. Not in every case, but at a population level, we can see changes that get instituted by providing effective messaging from trusted sources to change people's norms and behaviors. And so, for those of us who have been involved in public health, we know that we have tools at our disposal to encourage people to uptake services. We don't always get it right, but I think we have a moment right now where we both have the tools that are at the ready to be able to engage with populations and achieve the uptake that we're desiring. Over.
Great answer.
Thank you.
I am struck by, here in the United States, unfortunately, vaccine uptake has become so politicized, and it's really unfortunately become a blue state issue and a red state issue. And it's probably beyond the scope of this session to address how to deal with that. But we still have this 30% of Americans with full and free access to vaccines that for whatever reasons are not getting vaccinated. And that is what's driving the hospitalizations and deaths here in the United States. Dorgan, have you got another question for us?
Yes, next question is from Miriam. How long does the post-infection natural immunity last on average?
Yeah, so I can take that. Great question. I know we talked about the post-vaccination, how long does the immunity last, but you're asking about the natural infection. And that data is a little harder to get because it's not in a clinical trial that you enroll people who are previously infected. But there has been now a lot of publications that have shown data that anywhere between 90 days, so that is 3 months, to about a year or more, depending on the individual's immunity. But clearly it doesn't last forever, because even anecdotally, there are people who have been reinfected with coronavirus. So about, I would say 3 months to 6 months is probably a good bet.
Yeah. And then as Niru could elaborate on, I'm sure that there's getting infected. And what we saw with Omicron is people fully vaccinated and boosted were getting substantial rates of infection, but most of the infection resided in the upper airway. And there's a difference between virus that affects your upper airway and the virus that makes it down into your lungs, where it can do far more damage, that actually compromises your breathing, results in you going to an emergency room and getting hospitalized. And that's a combination of both the antibodies, which are particularly effective in preventing infection, but we also have our T-cell immunity, the cellular immunity, which kicks in to prevent the more severe outcomes of infection as well. So understanding that, I think we're also going to see advances in understanding the immune response to viruses that we could take advantage of.
Yeah.
So it's an exciting time to be a virologist and an immunologist.
Immunologist, yeah.
All right.
Next question is in fact addressed to Dr. Chabakuli, and it is from Kisito. What would have been model prediction, if any, of cases of death related to HIV, TB, and malaria if there were no COVID-19 pandemic?
We do not have that data yet. I haven't seen any modeling data for deaths as yet, but it's safe to say that it would have been substantial. It would be substantially less if it wasn't for COVID-19. And this is the reason why we have evidence and studies out there of what the lockdown particularly have done to the access and uptake of services for malaria, TB, and HIV has been. So the testing, for instance, have gone down. HIV testing has gone down by 41%. You look at TB referrals, it's gone down by 70%. Malaria diagnosis is gone down by 56% and treatment down by 59%. So indirectly, you can just see, I mean, these are conditions that if they're not attended to, the mortality is quite high. The case fatality rates are pretty high for malaria, for tuberculosis, and HIV. So it is just this indirect evidence that we have to infer that much of the deaths that we're seeing in 2020 and 2021 would be exacerbated by these barriers to access to the services.
Great. I think we have time maybe for one more, Dorgan.
Yep, I'll go ahead. A question from another attendee. Could you say a little more about the drugs being promoted at early signs of COVID onset?
Christian, do you want to handle that one?
Yeah, thanks. So this actually deserves its own whole talk. There are a couple of categories of therapies available. Immunoglobulins, monoclonal antibodies that can prevent severe disease, but then also antiviral, oral antivirals, and intravenous antivirals. I'm going to leave it at that because we don't really have enough time right now to get into all of that. But if we wanted to do another session where we're able to focus on that, I'd be keen to join.
sounds like a sales pitch, Christian. You're plugging for an invitation to come back and do part 2 of this. So on behalf of our FHI 360 colleagues, I'd like to thank Sid Washington so much for hosting this session and inviting us here. It's really a privilege for us to be able to talk to the community. I'm not sure if one of our SID colleagues will be coming on, but in the chat, there is an invitation for everyone to fill out the survey and to sign up for newsletters. And you could certainly check the SID Washington website for upcoming events that are in the series that FHI 360 is collaborating with SID Washington on. But anyway, from the FHI team, thank you so much. It's been a privilege to spend this hour with you all, and turn it over to SID Washington, or if not, to wish everybody a great day.
Thank you.
Great. Thanks so much.
Thank you, everyone.
Yeah, and there's a survey to be done there in the chat. Thank you.
Yes, we'll do that.